Good morning. Welcome to all to this quarter for the critical appraisal session. And I welcome the virtual participants as well. Thank you for joining. And today it's my pleasure and privilege to welcome and introduce Professor PRATHAP, THARYAN sir, Founder Director Corporate South Asia and Czech faculty of CEU. And sir has been patronizing all our events. Thank you so much, sir, for having come today. And it will be Dr. Janhawi who will be presenting the critical appraisal. And without any further delay, I'm happy to hand over to Dr. Janhawi for the presentation. Thank you.
Good morning, everyone. Today I'm presenting critical appraisal of an individual patient or participant data meta-analysis using AMSTAR 2 and CheckMAP tools. Let's look at a case. So, a 75-year-old gentleman was found with medicine with a history of hypertension for the past 20 years. He has come for a routine checkup and he's currently taking amlodipine to manage his blood pressure. It's a general patient and intern is seeing the patient. The patient asked the intern if he should continue the antihypertensive medication since he has been told that in his old age he shouldn't continue antihypertensive medication. But the intern recently read in a newspaper article that antihypertensives can decrease the risk of Alzheimer's disease. And he comes to you and asks what we should tell this patient. So we go and do a literature search. So since we are talking about treating hypertension and looking at outcomes, the best type of study to look at would be randomized control trials. So we went to Cochrane Library and looked for the keywords of dementia and hypertension because Alzheimer's dementia. And we found this 2021 review which looked at treatment of hypertension and outcome of cognitive impairment in dementia. So this study did the literature search in 2020 July. So we were looking at if there's any evidence after that. So this is when we come across this study. This is titled Blood Pressure, Antihypertensive Use and Late Life Alzheimer and Non-Alzheimer Dementia Risk. And it is an individual participant data meta-analysis. There is a QR code here if you would like to scan it. You can go to the website where this article is. It's an open access, so you can scan it and go to the article if you want to browse it as we go through the video. Or if you can search Lenin et al. In neurology, you'll be able to find this article. It was published in 2024 August. I'll go on. So let's just look at what a meta-analysis is. So meta-analysis is a statistical combination of results of two or more studies in order to answer a well-defined clinical question. It should follow a systematic review of the studies, including an extensive search for all the eligible studies that might be looking at the same clinical question and assessing what the risk of bias from these studies before putting together the results. A systematic review of meta-analysis usually uses summary data from the individual studies and not the individual participant data. And the steps are to calculate a summary statistic for each study so that they can be put together, and then calculation of the summary statistic or the combined effect of all the studies. What is an individual participant data meta-analysis? So when the available published or aggregate data is not of good quality for analysis, we have to collect, check and check and reanalyze the original data for each participant in the original study, and this will improve the quality of data and offset for inadequate reporting. It will give us the ability to analyze for results in a way that the original authors have not looked at. This needs to be done by a large collaborative group, the project management team, the original researchers who need to give this individual participant data to the management team, and an advisory group. And it is longer and costlier than doing a routine systematic review and meta-analysis. Something to keep in mind is that while it's a good thing to have different outcomes and different ways to analyze, this should be predefined, otherwise there is chance for mining the data to try and find results because so much participant data and variables are available. So let's look at the AMSTAR 2 checklist. It is a measurement tool to assess systematic reviews, and the second version came out in 2017, so that's AMSTAR 2. This is a free document available on the internet. It's in the BMJ article. It is applicable for systematic reviews with or without meta-analysis. It has 16 questions and it comes with a guidance document on how to apply the 16 questions. So let's move into the AMSTAR 2 checklist for this study. So the first question is, did the research questions and inclusion criteria of the review include components of PICO? So here it talks about studies that are looking at intervention Our study looks at both intervention and exposure. So I just mentioned here intervention and exposure. So it defines the population, intervention, exposure, comparative group and outcome. The authors do not predefine a time frame for follow-up. However, as long as we can answer, tick these four, we can say yes for the question 1. So if you look at the PICO for our patients, this study, so population is individuals that are at least 60-year-old from the cosmic cohorts. So the cosmic cohort is cohort studies of memory in an international consortium. So these are, I think, 17 studies they have as of now, which are looking at older patients, and they are looking at cognitive outcomes, so dementia or cognitive impairment or one of those. I will come to what the inclusion for cosmic was later. Exposure or intervention here are history of hypertension or treatment for hypertension. So they have defined hypertension history as reported by the patient as yes, I have hypertension, and treating patient is being treated. Yes, the patient is taking antihypertensive medicine. So this is one exposure. Another exposure is patient says yes, I have hypertension. I've been told to have hypertension, but not on any antihypertensives. So this is untreated hypertension. Another exposure they have looked at is the baseline blood pressure. The control group is patient says I don't have hypertension and the patient is not on any antihypertensives. This is their control arm. The outcomes are Alzheimer's dementia and non-Alzheimer's dementia. The time frame is not predefined by authors, but they say that the studies they included have a 2 to 15 year follow-up. So before we go further, I just wanted to bring to attention that what we looked at what a meta-analysis and that it should usually follow a systematic review. So meta-analysis can be done within a setting of a systematic review, but sometimes meta-analysis are done outside the scope of a systematic review. So as we go on to the checklist, we will try to identify whether this study is a meta-analysis which was done within a systematic review or without. So the studies that were included are the cosmic studies. So not all the 14 of the 17 studies they have been able to include. What are the cosmic studies? So to be part of this consortium, a study should be an epidemiological or population-based study, not a hospital-based study. Sample size of at least 500, individuals of at least 60 years of age, and it should be a longitudinal study with at least 2 assessments. Cognitive function is an important, if not the key outcome that they are looking at. And outcome measures should include dementia, cognitive impairment, or cognitive decline, any of these. For this trial, they looked at studies that at least had basic demographics, had to have diagnosis of Alzheimer's disease, yes or no, and blood pressure, hypertension history data. And so where these two match, these are the studies that they included. So if we, since the authors of the study have only looked at cosmic studies, if we go back to our previous picture, they haven't really done a systematic review. They haven't really looked for other studies outside of this cosmic consortium. There were no exclusion criteria at the study level other than the demographic, Alzheimer's diagnosis and hypertension data. But at a participant level, they excluded individual participants who were younger than 60 or older than 110, had diagnosis of dementia at baseline, those with missing data, which is a bit vague, and those where the systolic and diastolic blood pressure were outside 3 standard deviations from the mean. So the very significant outliers they have decided to exclude here. The next question in the AMSTAR checklist is whether the report of the review contains an explicit statement that the review methods were previously established before doing the study search and analysis. So the authors in the primary article state that they had a written pre-specified protocol that includes the review question and the inclusion-exclusion criteria in the protocol. However, they do not have a search strategy, they have not done any search outside of the cosmic studies, and they have not explicitly done a risk of bias assessment for each of the studies. So the answer here becomes no. And I wanted to highlight that this is the document which is the pre-specified analysis that they have cited and mentioned, which has been uploaded on the Open Science Framework, which is a freely available tool where since Cochrane and Prospero trial registration can take time, authors can upload their protocols on OSF where the date will be visible to everybody, and then the study, literature search and the systematic review and meta-analysis should have started after the protocol was published. So if we see here, this study was published in August 2024. They have created this protocol in May 2023. They have not specified when they did the analysis, and since they didn't do a search outside of the cosmic set of cohort studies, that question doesn't come here. Something interesting is that this document is in the past tense, and they include some of the results data, such as they have mentioned what the ±3 standard deviations of blood pressure is. So, which means that they have written this protocol after doing the analysis of the data. The next question is whether the review authors explain their selection of the study as why did they choose observational studies. I didn't mention that. So they have this cosmic all of them are cohort studies, right? So these are observational studies. So why did the authors choose observational studies for something? One of their exposure intervention. One of the things they're looking at is intervention, that is treatment for hypertension. So the explanation they give is that randomized control trials have a shorter follow-up than cohorts. It is a curated participant population who will be very adherent to the treatment and may not be generalizable in real life, and they may not have power to detect rare events. However, they themselves cite 2 randomized control trials and a meta-analysis of randomized control trials, which are around more than 2 and then 4 years of follow-up, which is similar to the mean follow-up in their own trial. And there do exist randomized control trials which are looking at the same data. So I am not convinced that there was any reason to exclude randomized control trials when they were trying to answer this question and only look at cohorts. The next question is whether the authors did a comprehensive literature search. So now it is becoming clear that the authors did not do this meta-analysis in the scope of a systematic review. So they have not done any literature search. The further questions are related to the same part of a systematic review about study selection and duplicate, data extraction and duplicate. So all of this is not mentioned. So study selection anyway was not done because they didn't do a study search. Data extraction they have not mentioned anything about. And excluded studies, even within the cosmic set of studies, they have excluded a few studies which did not have the outcome of interest. So that is all they have mentioned. The next question is on whether the review authors describe the included studies in detail. So the answer to this is yes, whether they describe the population, intervention, comparative outcome, the design, and the population in detail, the intervention and the comparator in detail, the setting and the time frame of follow-up. So all of this is given by the authors, and I'll come to that. So since there are 14 studies, I think it's becoming a little difficult to read here.
Or you just take us through what they have analyzed.
Yes, sir. This is just a baseline of, let's see if I can get it easier to read. So the things I wanted to highlight here, so I have put the table over 3 slides. These are the first 4 studies, and what I wanted to highlight is that most of the participants here are female, so less than 50% male in most of the studies. Some of them are having a high percentage of women. Take this out. I think you can see. So, on the top here, the columns are the ethno-racial group, the study name, the ethno-racial group, the mean age, the gender distribution, the mean years of education, maximum number of days is talking about how many times blood pressure was measured in these cohorts, maximum follow-up, mean follow-up, the mean systolic and diastolic blood pressure with standard deviation, and these are the status of hypertension and treatment for hypertension.
One second. The waves, this follow-up you're talking about is basically how many waves after, during the follow-up period, how many waves of blood pressure according to take?
I'm not sure about whether it was, I think the blood pressure readings are at
Well, because in the inclusion criteria it says baseline blood pressure is one recording.
one recording.
These was referred to
Subsequent blood pressure recordings. So here, this 1, 2, 3 and 4, I'll explain what this is. It was in the footnote, but I'm not able to fit it in the slide. So number 1 is the those without, they say I have no hypertension, not on medication. So number 1 is a control. Number 2 is I have no hypertension, but they were taking some hypertension medication, which may be for another indication. So this number 2 has been excluded, but it's a fairly small number in each of the groups. Number 3, which is usually the larger group in most of the studies, is yes, I have hypertension and on hypertension medication. So treated hypertension. And number 4 is, yes, I have hypertension, but not on any medication. So, untreated hypertension. If we look at this Henry et al. Study, it was done in 2 groups. So, that's why they have given the results separately. One was done in Africa and one was done in the US, in Indianapolis. So we have a black African population and black African American population. Most of these were women, so only around 30% men in each of them. And there is no data on hypertension and antihypertension drug use in both of them. Each of them has around 1700 people each. So they do have outcome, but they don't have hypertension. So how did they, what data did they put here in the analysis becomes the question. Then if we look at some of the other studies, hypertension data is available for most of them and the outcome data as well. And just highlighted including some of the other studies that were around 30 to 40% men only. Over here, this Vellore et al. Study, again the Leila study, again did not have hypertension and antihypertensive drug use data at all. This also had a little over 1,000 participants, if I am not mistaken. And what is getting missed here is the total. So let me see if I can close the slide. Okay. So if you look at the total, this is our mean age. So mean age of 72 with a standard deviation of 7. This is the 41% of the participants are men. We need to know this when we are looking at whether our patient whom we are trying to apply this data to really fits into these. So 72 years old, our patient is 75. Here we have a mean education. So 8.3 years of mean education in the participants with a standard deviation of 5.8. This is the mean follow-up of 4.2 years. And these are the hypertension, antihypertensive drug status. So of all the participants, 35.9% did not have hypertension, not on drugs. So this is our control arm. Number 3 and number 4 are our interventions. So 50.7% have hypertension and are being treated, and a small percent, less than 10%, have hypertension and not being treated. So for the question of whether the authors have described the study population in detail and the characteristics of the studies, they have. The next question in the AMSTAR is whether they use satisfactory technique to assess risk of bias. And in the tool, it is given as separately for RCTs and for non-randomized studies of intervention. So we can skip the RCT part and we come to the NRSI part. So the authors have not used any systematic way to look at risk of bias, but we can go into the supplement and the study to see if they have tried to look at risk of bias. So have they tried to look for confounding bias? The second part being, have they tried to assess risk of bias with selection bias? However, the authors themselves, by selecting studies from a consortium instead of doing systematic review, there already is a selection bias here. But they have not looked at selection bias at individual study level. They have assessed what methods were used to ascertain exposure and outcomes, and they have tried to harmonize these to make the outcomes look similar. So where education was primary, secondary, college, or in some studies education was reported as years of schooling, they have tried to make the outcomes look similar so that the data can eventually be pooled. So for schooling, they have assigned numbers. So if they have finished primary school, then 5 years of schooling. If they have finished high school, then it's 11 years and so on. So since we are not able to say yes for the risk of bias or selection, we will answer no to this question again. So what are the biases that we should look out for and see if authors have try to account for them. So one is the confounding bias, since all of these are observation studies. So they have told us which covariates they want to adjust for, but since if we go back to the document that was published on OSF, we don't know when the protocol was published. So they have defined some covariates, but we don't know whether these covariates were decided before doing the analysis. So that is a bit not clear. But they have adjusted for the covariates that they have chosen, and I will come to specific ones. The second one being the sample selection bias. So the authors have not looked at all the individual cohorts, how the cohorts were selected. The next one being whether there is bias in exposure and outcome measurement, and like I said earlier, they have looked at how exposure and outcome was measured in each of the studies and tried to harmonize the outcomes. There could be a recall bias in reporting of hypertension and treatment. I don't know if maybe somebody is going to develop dementia, they may not remember that they are taking, they are being told to have hypertension or taking medication. There could have been crossover. So patients who were diagnosed with hypertension not on medication, they got treatment. So how does this affect our analysis of results? Then Alzheimer's and non-Alzheimer's diagnosis was made by different diagnostic criteria, but they have given the tool used like DSM-3 or DSM-4 in the supplement for in each of the cohorts. The question of selective reporting. Several studies like we saw in the table did not report the exposure of interest, so the intervention of interest, which was hypertension and medication use. And they had, if we look at blood pressure, they had excluded these outliers of plus minus 3 standard deviations, anything beyond that. Since their protocol was not very obviously pre-published, we don't know if this decision was made post-hoc after looking at the analysis, so we don't know whether this was selective reporting. The next question is about whether the authors have looked at funding for each of the studies included in the review, and that they have given in quite good detail. And most of this is from government or different research grants. Only one pharmaceutical company is a funding agent here, and they have given an unconditional grant to the French ESPRIT project, which is one of the cohorts. The next question is if the meta-analysis was performed, which yes, the meta-analysis was performed, did the review authors use appropriate methods for the statistical combination of the results? So, have the authors justified combining the data in meta-analysis? I didn't see anything in the article where they are saying, but since the study was the meta-analysis itself, like they have not said explicitly why they chose to do this meta-analysis, whether they used a weighted technique to combine study results. Now, they have done a one-step individual participant data meta-analysis. So, meta-analysis of individual participant data can be done in two ways. Let's say I have two studies. So, let's say these blue participants are from study 1 and the red participants are from study 2. The authors could do this two ways. They could get a result for study 1, get a result for study 2 using the individual participant data, and then combine these two. So this would be a two-step idea. Here we would have to look at the difference, the heterogeneity in results from each of the studies as well. But what the authors have done is a one-step IPD. So this is so we took all the participants from all the studies and we pulled together all of their results into one result. This is one-step individual participant data analysis. So then I don't think we can really talk about heterogeneity of results in between studies. The second question of statistically combining effects and adjusting for confounding. So instead of adjusting for confounding in each study, they have taken individual participant data and they have the covariates that they chose, they have adjusted for that altogether. This question about summary estimates for RCT and non-randomized studies does not apply here.
So what's your score on this one?
I didn't take that. So it's yes. I will also just go a bit into detail about the statistical analysis and the covariates they chose. So this was a one-step individual participant data meta-analysis, like I said. They adjusted for age, sex, and ethno-racial group in a partial of their main analysis. They adjusted for education, dyslipidemia, body mass index, smoking status, and diabetes in the full analysis. So they have reported a partial and a full analysis. The main model or the partial analysis was run within each study, and they have said that they have examined for outliers and heterogeneity. They have not reported this in the main article, but they have done a two-step IPD and they have given a table of the two-step IPD in the supplement. And they have used mixed effect cost proportion hazards survival model for the analysis for adjusting for the covariates. So what does the cost proportion hazards survival model say? So So as the survival model tells us, what is the risk of the outcome we are looking at is the time to event, and the cost proportion hazard will be useful when we have a continuous variable exposure that we are looking at. So does continuous variables such as age or blood pressure affect the time to event? That's what we will try to answer with this. So if we talk about heterogeneity other than the results, there can be heterogeneity in covariate measurement, and I mentioned earlier about harmonization. There can harmonization of the outcomes. Covariates we know were not available in all the studies, and the two-step IPD I will show in the next slide. Sorry, that's coming later. This is about this slide I put up to show the missing data. So yes.
If these are RCTs, you need to adjust for all those.
These are not RCTs.
These are also. If they were RCTs, you need to adjust for the variables like age or each of the individuals.
See, I think what she's saying, what they did in their main analysis was a one-step analysis. Right? The problem with the one-step analysis is that you're treating this as one big humongous study. That's a problem. So I wouldn't be so generous as saying that an analysis is done, because you have to consider that each study is a cluster. You have to adjust for the cluster effect across studies if you're doing a one-step analysis. If you're doing a two-step analysis, you will find heterogeneity. That means each study's results are not combined with. That means that's the problem is there. Reporting the final result, because nobody will read supplement for the two-stage analysis.
This is the data on missing covariates. So because a lot of covariates were missing, model 1 is the partial analysis and model 2 is the partial analysis. And this percentage is how many of the studies or how many participants from the studies actually had all the data to do the analysis. So if you look at the partial analysis model 1, one of the study only had 16% of participants, and overall only 55% of the participants actually had the covariates for us to do the partial analysis. And not even 20% of the participants had enough data to do the main analysis. So even if we started with a big number, a lot of the covariates are missing, and when we look at the main analysis and the full analysis, we should keep in mind that it's only half of the cohort that we started with and only 20% of the cohort that we started with. The next question is assessing potential impact of risk of bias on individual studies. So they have not done a risk of bias assessment. They have not
given you a combination of study results and risk of bias.
They have.
Like you would do if you had a grade. There is no summary of findings.
There is no summary of findings. And looking at the results also, they have not talked about different risk of bias in each of the studies, and they have combined everything together without looking at that. Whether this is a question asked, whether the authors have given explanation or discussion of heterogeneity in the results of the review. So here I have put up the two-step meta-analysis that they gave us. So this is for Alzheimer's dementia's outcome and non-ADS outcome. So here we have treated hypertension, so that was the group 3. I have BP, I am being treated, versus healthy controls, no BP, not on medication. So they had a hazard ratio of 0.8, confidence level from 0.7 to 1.09, and heterogeneity of some 12%. In the untreated hypertension group, which was a smaller number, this is again compared to no hypertension, not on medication, and this had a hazard ratio of 1.34, again from confidence level from 0.8 to 2.1, and this had a higher heterogeneity of 63.5%. So the population was more different from each other in the untreated hypertension group. So if you look at this two-step analysis, they have not been able to show any increased risk of Alzheimer's dementia in untreated hypertensives as compared to non-hypertensive control patients, or in treated hypertensives compared to control arm. Even for non-Alzheimer's dementia, they have not found any significant difference. I think this is important to keep in mind, because they could have done two-step IPD, this didn't show anything, and at the end they have chosen to present the one-step IPD data. The last few questions of the AMSTAR checklist is if they performed the quantitative synthesis, did they give us a publication bias? So again, they have not done a systematic review, not looked for trials, and they have not given us a publication bias. It's not really relevant here in a way. Did the review authors report any potential sources of conflict? So the authors have reported their funding sources, and they have not said much about potential conflicts of interest, and but they have reported their funding sources. So that was the end of the AMSTAR 2 checklist. So I think what we could conclude from the AMSTAR 2 checklist, so the authors in their title never claim that this is a systematic review, but they do say that they are using the PRISMA IPD checklist for the reporting guidelines. So PRISMA is for systematic reviews and meta-analysis, and there is an update which includes additional things that need to be kept in mind for IPD. So they have claimed that they follow the PRISMA IPD checklist. They are not claimed that they do doing a systematic review, but the AMSTAR brings out that what are all the problems from not doing a systematic review, especially we do not have A, all the eligible data that should have been used for the study, B, there is no risk of bias assessment, and even the protocol it doesn't look like it was really pre-specified. Another tool which is more specific for individual participative meta-analysis is the CheckMAP tool. This has 10 questions, but it's a paid tool, so we had to buy it and then use it. So I'll go through this. First question again in this tool is also, was the IPD meta-analysis project done within a systematic review framework? And the answer here is no. The next question is, so they asked us to try and consider if the authors haven't said that we are doing a systematic review, but maybe they have done it, so go through it and see. So first question that comes is, have they made a pre-specified protocol? So that, as we know, is in question. Whether they have given a clear research question, eligibility criteria, so I think that was fairly done. Whether they have done a systematic search, which they haven't done. Whether they have a consistent approach to data collection, it seems so. They have not done a risk of bias assessment, and the meta-analysis method, whether again there is a whole big question mark about the protocol being pre-specified. And two researchers independently checking classifications is also not explicitly mentioned in their methods. The next question is, were the methods of the IPD meta-analysis project pre-specified? We have already looked at this question. The next question is, was there a clear research question and explicit eligibility criteria of the trial and participants? So the participants, yes, trial, no. The only inclusion criteria was that they should be from this cosmic consortium and have the variables of interest. The next question is, did the IPD meta-analysis project use a systematic and nominal? Sorry, these are the variables going to use here. The next question is, so whether the IPD obtained for most of the eligible trials and their participants. So the first question in this is, were the data for individual participants obtained for a large proportion of eligible trials? So no, because they didn't look for eligible trials. The next question is, was this representative of all high quality trials? No. And whether of the eligible participants. Now, if we say that of the studies they chose, did they look at all the patient data? Yes, but then again, they have not looked at all the eligible studies, so I think we can answer no for this. They have a lot of missing data, which they have not explained how they accounted for. They have reduced the numbers that they have published in the meta-analysis, and they did not specify if there were any discrepancies in the when they looked at the study and what they found versus what the author said in the study. So none of that is given. Risk of bias was not assessed, and whether the methods of meta-analysis were appropriate. So for this question, the CheckMAP trial gives us a few sub-questions which we can use to try and answer this part. But we should, sir?
That's where it says, researchers
yes, sir.
clustering of participants within trials with their meta-analysis method. So the choice of one or two stage meta-analysis appropriate and specified in advance, and the results they give, the results will they have not told us that the results will prove that is
So the first question question came whether the analysis methods were pre-specified, again not clear. Whether the method of summarizing overall effects. So I thought that IPD, but like sir said, the heterogeneity of the populations means that we may not be able to put together all the data in a one step.
You can, but you need to
Account for the clustering. So I actually put this in red because I wasn't sure how to say if they have accounted for clustering. They said they've taken a random study effect as a covariate, but not for clustering.
That doesn't account for clustering. What happens when you have clustered study, it tends to narrow confidence intervals and give you more precise results.
Then again, so query pre-specified that they'll do one-stage study, and they have done a two-stage meta-analysis, but like we saw, the results are different and they have not highlighted that in their paper. Again, the between trial heterogeneity was examined and published in the supplement, but not accounted for. This I was not able to, maybe sir can help with this. So,
I think this applies to the fact that sometimes when you do an IPD meta-analysis, you find that they get a lot of trials. And some of those trials they can get individual patient data, and some they can't. So then they have to account for both. So these questions refer to
when they're doing a trial meta-analysis. I have just put this table again to show the difference in the outcome. And so the project report says that they cover the items described in the PRISMA IPD, but if you look at the PRISMA IPD, it includes articles such as risk of bias, which they clearly have not given. After looking at all of this and looking at the limitations of the study, one that not a systematic review, second, the method of analysis may not have been appropriate and they have not accounted for clustering effect within the different cohorts. We will just look at the results. So this is the primary outcome of Alzheimer's disease. Here we have treated hypertension, here we have untreated hypertension, and it is being compared with healthy controls. We saw the similar data from the two-step. Here, the results that are, I'm just highlighting the results that are positive. So here, they are trying to show that untreated hypertension has a hazard ratio of 1.36 with a confidence interval from 1.01 to 1.8 of developing Alzheimer's dementia as compared to a healthy control. And this is in the main analysis which adjusted for age. They have taken age squared because there is a quadratic association between dementia incidence and age. So not a linear relation. As the age increases, dementia is, because of age, goes up in a quadratic fashion. So age squared, sex, education, ethno-racial group, and a random effect for study. So with that, this was the hazard ratio. And when they do a full analysis where they also include BMI, smoking status, dyslipidemia, and diabetes, they still have a hazard ratio of 1.7, suggesting that untreated hypertension puts you at risk of Alzheimer's dementia. They have tried, they've done a subgroup analysis where they have restricted to those where the diagnosis is after 5 years. They have tried to justify this as if you develop dementia within 5 years, it may be unrelated to the exposure of hypertension and treatment, which was done at the time of recruitment, maybe because of factors that came before that. So when they do this restricted analysis, then this risk becomes non-significant. And this third column is the total, where they have compared untreated hypertension to treated hypertension and try to say that untreated hypertension compared to treated hypertension also puts you at a higher risk of Alzheimer's. If you look at non-Alzheimer's dementia, in the main analysis, treated hypertension and untreated hypertension are putting you at a higher risk of developing non-Alzheimer's dementia as compared to healthy controls. So hypertension, like whether you're treated or not, is putting you at higher risk for non-Alzheimer's dementia, but on fully adjusting for some of the covariates, I think which are important. Diabetes, BMI, dyslipidemia are important covariates that should be adjusted, but I'm more interested in the fully adjusted analysis. The reason they are highlighting the main analysis is because fully adjusted only 20% of the participants are still available. So this becomes non-significant in the fully adjusted result. Then there was a subgroup analysis, so they have put here in this first plot, main analysis fully adjusted, more than 5 year which you already saw, and they have also done 60 to 70, 70 to 80 and so on. They have looked at gender and ethno-racial groups as well. So They have tried to highlight that in non-Alzheimer's dementia, men with treated or untreated hypertension seems to be at a higher risk of developing non-Alzheimer's dementia, but not women. And they have tried to say that there is some relation of age, though, if you look at treated hypertension, for the younger group. So basically, in the younger group, having hypertension and being treated for hypertension puts you at a higher risk than controls, and this difference, as you become older, becomes less and less. So, despite adjusting for age. This was the other exposure that they looked at, which was baseline BP and dementia risk. So they had at least one BP reading at the recruitment in cohorts, and which is what they have used. So systolic and diastolic BP, and none of them had any. So this table is for Alzheimer's, and the next table is for non-Alzheimer's. So Alzheimer's, there is no association of blood pressure reading with risk of developing dementia. And for non-Alzheimer's, only when they restrict to a more than 5-year age of diagnosis of dementia, they are finding that blood pressure of 180 and systolic of 180 and diastolic of 60 may have some association with increased risk of non-Alzheimer's dementia. But in the fully adjusted analysis, this effect is not there. So I wouldn't consider it to be important. Then they have looked at a cubic spline model. So if you just look at the x-axis, this is blood pressure, and if you look at the y-axis, this is the hazard ratio, and this here is 1. So in red we have risk of Alzheimer's dementia, in blue we have risk of non-Alzheimer's dementia, and we are trying to see if there is any association with age, like at blood pressure. At extremes of blood pressure does the risk change. So here for both Alzheimer's and non-Alzheimer's, the lines are mostly flat. Maybe for non-Alzheimer's at a lower blood pressure, the risk is high, which is similar to what we saw in the previous table. And here, if you look at the green line, which is the non-Alzheimer's dementia risk, maybe at lower BPs there is a little higher risk, and maybe once the blood pressure goes high, there is a little higher risk of hazard ratio. So I'm not. I didn't need to show this graph to say that this result is very believable or important, but just wanted to show this is another way where data can be presented. They said that they use this type of a model because blood pressure is shown to have a U-shaped correlation with dementia risk in other studies, which is why they use this one. This is for the partially adjusted group, and this is for the fully adjusted. So for fully adjusted, there doesn't seem to be much of a correlation between blood pressure and hazard of developing Alzheimer's or non-Alzheimer's dementia. And this is after restricting to more than 5 years follow-up. This was what we saw in that table in yellow. So if you just summarize the results that they have given, they have said that untreated hypertension has a ratio of developing Alzheimer's disease of 1.36, and after fully adjusting for covariance of 1.7 times that of controls not having hypertension or being treated. There was no risk influence of developing non-Alzheimer's dementia based on the diagnosis and treatment for hypertension, and they tried to show that men and maybe younger age had a higher risk of developing non-Alzheimer's dementia related to having treated hypertension. So there are several limitations of the study. No systematic reviews. They have not used data from randomized control trials, even though it exists. They could have used both randomized control trial and observational study data. There is risk of bias in exposure and outcome measure, reporting bias, and the analysis is questionable. And the 2 types of analysis that they have done show different results, but they are not accounted for it. So our gentleman with 75-year-old hypertensive who wanted to stop his medication, and our intern was interested in knowing whether continuing his treatment decreases his risk of Alzheimer's. Based on the study, untreated hypertension seems to have increased risk of developing AD, but I would take the results of the study with a pinch of salt. However, the studies that the authors have quoted do show benefit of treating hypertension in terms of preventing risk of Alzheimer's dementia. So I would continue antihypertensive therapy in our patient.
Open for discussion.
they found some 8 RCTs of very poor quality and said, we can't make any conclusion. They didn't update it from then to 2024. This is the only evidence available in 2024. So it is poorly done.
No,
Not poorly done, but not.
in the sense it's very difficult to do an interpretation. I read the editorial of this, and they're saying it's very complicated to understand the results of this. They tried to do the best they could. They have looked at various confounders and stuff. But there are, see, one of the things they seem to have done is saying, in earlier studies which did not find the association, they used categorical cutoffs for hypertension, this, that, and the other. So we want to do continuous one, which is why they did their Cox. But the problem, if you look at the data table, they have continuous variables for a few. The rest of them are all categorical, right?
Even the hypertension is categorized.
All categorical. So they have taken what data they could get from their cohorts and done analysis, which seems to show associations. When you extend it to the others, it doesn't show. Then the other question is, see, intuitively you have to ask yourself, what do the results say? That if you are untreated hypertension, right, you will get Alzheimer's disease. Intuitively you thought you get non-Alzheimer's, you get strokes and vascular dementia. So somehow I don't understand what that's why the editorial said, the biological mechanism underlying their findings is obscure. But it could also be that increasingly we are finding that this diagnosis of Alzheimer's disease, many of these people with Alzheimer's disease have also got vascular changes. So these categorical things that we are making may be part of the problem. And the other thing is they looked at one baseline. You can't diagnose hypertension with just one baseline recording anyway. So there are a lot of issues which confound this whole field of, so I don't blame them. I think they've tried their best. But I'm very glad that you came back to your patient and said, see, I've read the literature, I'm as confused as before, but whatever you do, please continue your treatment. Unless it's causing problems. The only thing they are also talking about is the fact that if you reduce people's blood pressure too much, diastolic blood pressure too much, that can be dangerous. So that I can see from that. Anyway, I congratulate you for trying to look at an IPD meta-analysis of this complexity. Any other questions? I would actually advise you to read the Prisma IPD document and the explanation. That will explain what are the issues. The CheckMAP is a kind of trying to get money from you and taking Prisma IPD and making a checklist of their own. That doesn't really give you anything more than reading the Prisma IPD document. If you just put up the Prisma IPD, and if you just go through that, you'll find. The checklist is good, but if you read the actual document, it gives you explanations on why you should be looking at all of this. So if you look at that, you'll find that everything you find in CheckMAP is taken from this, right? But if you look at the results section, the methods for criteria.
Share the screen, please.
Oh, this one is letter.
So you'll find things like IPD integrity. What aspects of the IPD are subject to data checking? So what they're trying to tell you is that IPD you should be describing from each study, each cohort, what were the methods of that cohort, how well was it done, and stuff. Now maybe they did it in some supplement and all that stuff, but we don't get an idea of how well this thing was done. Describe methods used to assess risk of bias and this is applied separately for each outcome. So now we're looking at terms of outcome-specific risk of bias. So ideally when they do their outcome assessment, They give us a aggregate forest plot. They should give us an overall summary is, do they trust this result? So those are the problems and I don't blame them because it's difficult to do. It's not been developed. There is no agreed to tool for IPD. So we are trying to use in those methods which are applicable for individual systematic reviews of interventions through IPD meta-analysis. It's complicated. I commend them for what they're trying to do, but I suspect there is a little bit of reporting bias because the supplement findings will be quite discrepant. See, what you're then doing, you're saying, when you do, you have to see whether there is coherence between one model and the other model. Like you say, this is like sensitivity analysis. Are my results different depending on what model I'm applying? 2 stage, 1 stage. None of that has come out. That's my concern.
They have done, the same authors have published one on or any dementia. So last year they have published from the same cohort studies. They have been able to include all the 17 of the cosmic studies. They have published a paper on any dementia, and after that they have published this on specifically Alzheimer's and non-Alzheimer's. So
what did they find?
I suspect that similar, saying that the treatment of hypertension will, but it's the same study, so a few more studies have been added. But I suspect that they had that, and from that they have
When you said that they only chose their cohorts, yes and no, in the sense that to get high quality data, very often IPD has to be prospective. You have to assemble your treatment, your team, and specify what kind of outcomes, what definition they are going to use, and then follow them up for a period of time. So it's possible that when they get longer periods to follow, because if you look at mean follow-up is 3 years. Right? And some of these people are 60 years. You don't expect them all to get dementia by 63. So I think that maybe when they get longer follow-up, they might find more usable results. So anyway.
Many things like many guidelines are quoting this article to say that because Alzheimer's is becoming a big issue in India now, so say treat your hypertension when you can treat. People will not read this and carefully make a call.
Now that from a patient's point of view, does it matter whether you have Alzheimer's or non-Alzheimer's?
Hypertension has to get treated anyway.
You have to treat. Well, for the carer, do not bother about whether you have Alzheimer's or non-Alzheimer's. Actually, the importance of Alzheimer's is because of the kind of drug that we used to target in plaque reducing and this and that and all kinds of stuff. So there's a huge industry going on based on how you make your claim. So unless there is a ICD category for the drug, no insurance will pay. So you can have whatever label you give it, as long as everybody believes this is the label, you make money off it. So I think from a patient's point of view, if you are saying that if I have got treatment and I have to treat very aggressively, there's a problem. So the guidelines should be nuanced, saying, this U-shaped curve is something which should actually come out saying there is a U-shaped curve between treating people and trying to prevent the outcome. I don't know. Anybody else? Any other thoughts?
The online university.
Near the online participants, if you have got any questions, you can type in or you can unmute yourself and ask the questions.
What is the program you're using to present? The PowerPoint slide? What's your template?
in sense of,
It's very interesting, your template, your slides.
it was just from the designs that it suggests, and I used smart art.
Or you use. You are not. Out of myself, no, who was presenting